Welcome to the deep dive. Today we're tackling a critical topic in intensive care. Continuous electroencephalography, or cEEG monitoring. You, our curious listener, shared a fascinating set of sources with us. There's a survey on cEEG use in Dutch ICUs, a guideline outlining the technical, best practices for EEG in this challenging environment.
Right, the ICU setting.
Exactly. And an article really focused on demystifying the often bewildering world of EEG artifacts.
Yeah, those could be tricky.
So our goal today is pretty straightforward.
Yeah.
Extract the essential knowledge about how cEEG is being used, what factors cause variations in its application, and crucially, why being able to tell a genuine brain signal from all that electrical noise in the ICU is just so incredibly important.
Exactly. We're essentially piecing together a picture of cEEG in practice.
We'll start by looking at how it's being implemented over in the Netherlands. The organizational structures, the main reasons doctors use it, and the different approaches hospitals are taking.
Oh. Then we'll delve into the technical nuts and bolts of getting a reliable EEG recording in that high-tech ICU environment. We're talking electrodes, equipment interference, all that stuff.
Right.
And finally, we'll arm you with the knowledge to understand or at least recognize the various types of artifacts that can really muddy the waters and make interpretation difficult.
Okay, let's start then with this Dutch survey. It paints a picture, it seems, of cEEG becoming more and more common in ICUs across the Netherlands.
That's definitely the overarching trend, yeah. The survey of neurologists and intensivists there clearly shows this growing recognition of the value of continuous EEG for managing critically ill patients.
So it reflects a broader understanding.
I think so. A broader understanding of just how dynamic brain activity can be in this, well, vulnerable population.
But what's really interesting, and you flagged this, is that even with this increasing use, the survey points to some pretty significant differences in how cEEG is actually done from one hospital to another. And it doesn't seem neatly tied to whether it's like a small community hospital or a big university medical center.
That's a really key takeaway. Despite the general trend towards more cEEG, standardization is lagging behind a bit.
How so?
Well, for example, while starting a cEEG during normal office hours seems possible everywhere they offer it,
Okay.
the ability to kick one off during evenings, nights, or weekends, that's much less consistent across the board.
Right, which could be critical in an emergency. And it sounds like the length of time patients are actually monitored also varies quite a bit.
Precisely. The survey suggests university and teaching hospitals, they tend to monitor for longer periods, typically, 24 to 48 hours, maybe even longer.
And the general hospitals.
In contrast, general hospitals seem to lean towards shorter recording times.
Now, in an emergency, having a neurologist who can actually interpret these complex brain waves seems absolutely critical. What did the survey find about that expertise being available, say, 24/7?
Well, the survey indicates about 70% of hospitals doing cEEG report having neurologists available for emergency review around the clock.
Which sounds pretty good, but...
But yeah, there's a catch. These services can be limited, staffing shortages are one issue, or crucially, a lack of technology like telemonitoring.
Tele-monitoring. Being able to look at an EEG remotely, that seems like such a game changer. What's the story there in the Netherlands?
It really highlights a stark contrast depending on the hospital type. All university hospitals in the survey reported having telemonitoring capability.
All of them, wow.
Yep, around 2/3, maybe 64% of teaching hospitals did. But get this, not a single general hospital in the survey had this technology in place.
Zero.
Zero. So this disparity in remote review, it likely contributes to the challenges in providing truly continuous monitoring, especially in those smaller centers.
Yeah, you can see how that lack of remote access in general hospitals could really impact how quickly critical events get identified and managed. So, okay, when Dutch doctors are ordering a cEEG, what are the main reasons? What triggers that decision?
The number one reason, and this lines up pretty well with what we see in the U.S., is to detect and monitor non-convulsive seizures and non-convulsive status epilepticus, NCSE.
Okay, and NCSE, silent seizures, essentially.
Right. And the survey responses suggest a good awareness of how common NCSE might be in the general ICU population. Most estimates were below 25%, which is pretty consistent with published research.
And if a hospital in the Netherlands has cEEG capabilities, it sounds like they're definitely using it when they suspect NCSE.
That's right. All the hospitals in the survey offering cEEG reported using it for identifying and managing non-convulsive seizures and status epilepticus. It reflects the strong recommendations from various professional guidelines.
Makes sense. What's the second most common reason they use it over there?
Prognostication, specifically in patients who've suffered a cardiac event.
Ah, predicting outcomes after cardiac arrest, for instance.
Exactly.
Yeah.
There's growing evidence that EEG patterns can give really valuable information for predicting outcomes in that specific patient group. And Dutch practice seems to be reflecting this evolving understanding.
Interestingly, though, the survey found that using cEEG to look for ischemia, reduced blood flow in patients with subarachnoid hemorrhage,
Yeah?
which is something we do see in some U.S. centers. Apparently wasn't reported at all in the Netherlands. That's a fascinating difference.
It is, isn't it? Could it just be awareness or maybe different treatment protocols or resources for SAH patients in Dutch ICUs? It's hard to say for sure.
What did the survey authors think?
Well, they suggested that maybe a lack of familiarity with that specific application of ICU cEEG might be a factor. It just highlights how even within well-established medical communities, certain specialized practices might not catch on universally.
Okay, one final point from that survey that really struck me. The distinction between continuously recording the EEG and continuously monitoring it.
Ah, yes. Important difference.
It sounds like a lot of hospitals are equipped to do the first part, the recording, but the second part, having someone actively watching and interpreting the data in real time, that's less consistently available.
That's a crucial point. The survey showed significant variation in how frequently the recorded EEG data is actually reviewed by experts.
So the machine might be running, but nobody's looking.
Not necessarily nobody, but perhaps not continuously. It suggests that while the tech for continuous recording might be widespread, the resources for truly continuous expert monitoring, the kind that allows for immediate intervention when critical changes happen, aren't always in place.
And that potential delay in spotting things like non-convulsive seizures could have a real impact on patient outcomes, couldn't it?
It certainly could. Understanding this varied landscape in the Netherlands really underscores why the technical aspects we're about to jump into are so critical. If practices differ so much, the need for reliable, accurate EEG signals becomes even more paramount.
Okay, perfect transition. So we have a clearer picture of cEEG use in Dutch ICUs. It's increasing, but with big differences in organization and actual monitoring. Now, let's shift focus to the technical side. Our guideline article really hammers home that getting a high-quality EEG signal is absolutely essential,
Couldn't agree more.
especially in the ICU where stakes are so high and big treatment decisions often hang on this data. Absolutely. The clinical value of cEEG is entirely dependent on the reliability of that underlying signal. The guideline starts by reminding us of some basic neurophysiology. And EEG primarily reflects the summed electrical activity, specifically those postsynaptic potentials from large groups of neurons in the brain's cortex.
And it takes quite a few neurons firing together to make a detectable signal.
It does. You need a relatively large area of synchronized firing, roughly 6 square centimeters they estimate, to generate a signal strong enough to be picked up on the scalp. And even then, these potentials are tiny, like 10 to 100 microvolts. Really small.
And these incredibly small electrical signals have to travel through several layers before they even hit the electrodes on the scalp, right?
Exactly. They pass through the cerebrospinal fluid, the durameter, the skull, the skin, all acting as electrical barriers, basically impeding the signal flow.
Impedance.
Right. And then the electrodes themselves and the wires connecting them add even more impedance or resistance to that electrical current.
Impedance. Okay, that's clearly a really important concept here. What's the ideal level we should aim for when setting up the electrodes?
Well, international guidelines generally recommend keeping electrode impedance below 5 kiloohms, 5 key.
Okay.
However, the guideline we looked at really stresses that having consistent impedance across all the electrodes is just as, if not more, important.
Why is consistency so critical?
It comes down to something called common mode rejection. Think of it as the EEG machine's ability to subtract out the background hum electrical noise that's hitting all the electrodes equally.
Ah, like filtering out interference.
Exactly. Uniform impedance helps this subtraction process work effectively, leaving you with just the unique brain signals you want to see.
So what happens if we have electrodes with really high impedance, or if the levels are all over the place between electrodes?
Well, high impedance can make that common mode rejection less effective, leading to a noisier recording overall. And non-uniform impedance, that just makes it worse, because the common noise isn't really common anymore, so the subtraction gets less accurate.
Okay.
Plus, high impedance can make the recording more susceptible to artifacts generated right at the skin electrode interface, Little pops and crackles.
I see. So even if newer machines can maybe handle slightly higher impedance.
Yeah, some modern amplifiers have very high input impedance and might tolerate it a bit better, but the practical advice, honestly, is still to aim for lower, more uniform impedances, ideally below 10K, definitely below 5 if you can manage it, just to ensure a clean, reliable signal.
Makes sense. Like trying to hear someone through a thick, uneven wall versus a thin, uniform curtain.
That's a pretty good analogy, yeah. Much clearer through the thin curtain.
Okay, let's talk about the electrodes themselves. Sounds like there are two main types commonly used for cEEG in the ICU.
Yes. Cup electrodes are probably the most versatile and widely used. They're applied to the scalp using a conductive adhesive.
Like little cups glued on.
Pretty much. They're flexible, you can adapt them to various situations, even if the patient has skull defects or intracranial pressure monitoring going on. They work for short and long-term CEE.
Any downsides?
Well, the guideline suggests for really long recordings, you might need brief breaks to check the skin underneath. And applying them properly takes trained personnel. MRI-compatible versions are available too, which is useful.
Okay, cup electrodes. And the other main type?
Subdermal wire or needle electrodes. These are a good alternative, especially for patients who are comatose.
Needles. That sounds a bit more invasive.
Slightly, yes. They're inserted just under the skin.
Yeah.
Because of that, they tend to maintain a really stable impedance over long periods and can be less prone to certain artifacts compared to surface electrodes.
The advantages.
Stable impedance, potentially fewer artifacts. MRI-compatible options exist, and you don't need skin preparation. But yeah, their slightly more invasive nature generally limits them to comatose patients, and often you use fewer electrodes compared to a full cup setup.
Got it. What about the glues or pastes used to stick these on? Collodion and EC2 paste were mentioned.
Right. Collodion has a long history in EEG, especially for cEEG, where you need strong, long-lasting adhesion. It's basically nitrocellulose dissolved in ether and alcohol.
Ether. Isn't that flammable and potentially toxic?
Historically, there were concerns, yeah. But the guideline points out that in a well-ventilated ICU environment, the concentrations are unlikely to reach dangerous levels. It forms a rigid film that holds the electrode really securely.
Then EC2 paste.
That's presented as a cost-effective and increasingly popular alternative. Crucially, it doesn't contain ether. Studies have shown it gives impedance levels comparable to, or maybe even better than, collodion, both initially and over a 24-hour recording.
Interesting. Okay, so we've got electrodes on, hopefully with good, consistent contact. Now, how do we fine-tune the recording itself? Let's talk filters. What are the standard settings for ICU EEG?
Generally similar to routine EEG settings. You have a low-frequency filter or high-pass filter, usually set between 0.5 and 1 hertz. That helps remove slow, non-brain activity drifts.
Okay.
Then there's a high-frequency filter or low-pass filter, typically set around 70 hertz to cut down on high-frequency noise, like muscle artifact.
What about the notch filter for power line interference?
Yeah, the 50 or 60 hertz notch filter. Depending on where you are, it should be used cautiously, really only when necessary.
Why cautiously?
Well, 2 reasons. First, prominent 60 hertz artifact can actually be a helpful clue,
Yeah.
but often means you have a bad electrode connection somewhere.
Yeah.
So starting without the filter can help troubleshoot.
Ah.
Second, the notch filter can sometimes distort the shape of actual sharp brain activity if it's too aggressive or if the brain activity falls close to that 50 or 60 hertz range.
Yeah.
So use it, but know what it might be doing to the signal.
Right. Makes sense. Video recording seems like it would be absolutely essential in the ICU with everything going on around the patient.
Oh, absolutely essential. Highly recommended, really. Given the constant nursing care, medical procedures, all the potential artifact sources, simultaneous video is crucial.
How does it help specifically?
It allows direct correlation between what you see the patient doing, movements, facial expressions, even staff actions causing bumps or noise, and the patterns on the EEG. Essential for spotting subtle seizures and, again, distinguishing real brain activity from artifacts.
What should the video capture?
Ideally, the patient's face, arms, and upper trunk. And you need to check the camera position regularly because beds get moved, equipment gets shifted around the bedside constantly.
Good point. There are also a whole host of other factors in the ICU that can mess with the EEG interpretation, right? Things like body temperature, medications.
That's correct. Body temperature has a big impact. Hypothermia, especially below about 30 degrees Celsius, progressively slows the EEG. So documenting the patient's temperature during the recording is vital.
And meds.
Oh yeah. Sedatives, antipsychotics, even some anti-seizure drugs themselves, opioids, certain antibiotics, they can all alter EEG patterns. Having a complete, up-to-date medication list is absolutely crucial for accurate interpretation. You have to know what the brain is being exposed to.
What about physical things, like if someone has had brain surgery and has a skull defect, or just normal muscle activity?
Skull defects, even small ones, can cause a localized increase in EEG amplitude in faster frequencies. It's called breach rhythm. It can be misleading if the interpreter doesn't know about the defect. And muscle activity, huge source of artifact. Involuntary movements like myoclonus, tremors, shivering, even just jaw clenching or neck tension, all generate substantial artifact that can obscure brain activity or even mimic spikes.
Can you do anything about that muscle noise?
In patients who are intubated and unresponsive, sometimes short-acting neuromuscular blocking agents, paralytics, can be used, along with adequate sedation, of course. That temporarily eliminates the muscle artifact for a clearer look at the brain activity itself.
Assessing the reactivity of the background EEG to stimuli sounds important for prognosis, especially in consciousness disorders.
Yes, seeing how the background EEG responds to various stimuli is key for evaluating patients after, say, anoxia or traumatic brain injury, assuming there are no concerns about raising intracranial pressure.
What's the standard approach?
Usually you apply stimuli sequentially. Start simple. Eye-opening if possible, then auditory stimuli, like a clap or voice. If no change, then noxious stimuli.
Painful stimuli.
Yes, but applied carefully. Trunk stimulation, like a sternal lub, is generally preferred over pinching a limb, as limb responses can be unreliable. And it's absolutely critical to document the exact type, timing, and duration of every stimulus right on the EEG recording itself.
Makes sense. And finally, the big question. How long should a cEEG recording actually last in the ICU? Is there a consensus?
Still some debate there, but many guidelines suggest a minimum of 24 hours for patients who aren't comatose and 48 hours for those who are comatose. That's mainly to maximize the chance of catching seizures.
Do most seizures happen early on?
Interestingly, yes. Research shows the majority of seizures picked up by cEEG tend to occur relatively early in the recording. But the decision on duration really needs to be case by case. You have to consider the clinical picture, why you're doing the cEEG, and frankly, the availability of EEG resources.
What if you see suspicious activity but no clear seizures?
If you see definite epileptiform activity, maybe running it for 16 to 24 hours without capturing a clear seizure might be enough to help rule one out in that period. If the recording looks pretty clean, without epileptiform discharges, shorter durations, maybe 2 to 5 hours, might suffice for certain questions.
But for some conditions, it's definitely needed longer.
Oh, absolutely. For managing refractory status epilepticus ongoing seizures, cEEG is strongly recommended, and it should definitely be considered for any patient with unexplained altered consciousness.
Okay, so we've covered the how and the why of cEEG use and the technical nitty-gritty. Now we hit what seems like one of the biggest hurdles in the ICU, the artifact jungle.
Uh-huh. It really is a jungle sometimes.
Our dedicated article really drives home just how artifact-rich the ICU environment is. Given all those variations in practice we talked about, being able to confidently tell real brain activity from artifact seems absolutely essential for any meaningful interpretation.
Absolutely. The sheer density of electrical equipment, the constant medical activity, it makes the ICU a prime spot for generating stuff that contaminates the EEG.
And this is where the EEG technologist comes in.
Indispensable.
Yeah.
They are the first line of defense, identifying artifacts, troubleshooting them, trying to figure out if it's brain or noise. As our source stated clearly, the recording isn't really done until you've answered that fundamental question: cerebral or artifact.
The article helpfully splits artifacts into physiological from the patient's body and non-physiological from outside sources. Let's start with physiological. Muscle activity, EMG, body movements, seems like they'd be super common.
Oh, extremely common. EMG from scalp, face, jaw, neck muscles, especially if the patient's awake, anxious, in pain, or maybe biting an endotracheal tube. This muscle noise can easily mimic fast brain waves like beta activity or even look like sharp spikes.
And actual movements.
Yeah, involuntary movements, twitches, tremors, itics, even the movements during a seizure itself can cause huge artifacts just by physically moving the electrodes or wires. Rhythmic movements can create rhythmic artifacts that might look worryingly like a seizure pattern.
You mentioned paralytics earlier for muscle noise.
Right. In intubated, unresponsive patients, neuromuscular blockers plus sedation can eliminate both muscle tension artifact and movement artifact, giving you that clearer window into the brain's activity.
EKG artifact, the heart's electrical signal interfering. I imagine that's another constant battle in the ICU.
Very common, yes. EKG artifact has that sharp, repetitive waveform that can easily be mistaken for epileptiform spikes on the EEG.
Can you get rid of it?
Not completely, usually.
Yeah.
But recording an EKG channel simultaneously with the EEG is absolutely essential for identifying it. You see the spike on the EKG and the corresponding blip on the EEG, and you know what it is.
Any tricks to reduce it?
Yeah. Sometimes just adjusting the patient's head position can help minimize its amplitude on the EEG channels. And definitely avoid placing EEG electrodes right over implanted pacemakers. Those high-frequency pulses will contaminate the recording badly.
Okay. Cardioballistogram and pulse artifacts, those sound a bit more specific.
Yeah. Cardioballistogram artifact shows up as widespread, rhythmic slow waves on the EEG, time-locked to the heartbeat, usually appearing just slightly after the QRS complex on the EKG. You see it more often when the background brain activity is already suppressed or flat.
And pulse artifact.
That happens when an electrode is accidentally placed right over a pulsating artery or maybe some swollen vascular tissue. It creates an artifact that mimics focal slowing, looks like a slow wave just under that one electrode.
How do you spot that one?
Often you can just gently touch the electrode and feel the pulsation. Repositioning the electrode or slightly adjusting the head usually fixes it.
Glossokinetic potential, that's tongue movement, right?
That's right, GKP. The tongue acts like a little electrical dipole, so when it moves, it generates an artifact, especially picked up by the frontopolar leads, the ones nearest the mouth.
Tricky if the patient is moving their tongue a lot.
Can be, especially in uncooperative patients or just the general dynamic ICU setting. Sometimes adding a dedicated channel to monitor tongue movement can help correlate the artifact with the movement.
Okay. And then we have electroretinogram ERG from eye movements and sweat artifact.
Yep. ERG artifact is the electrical activity from the retina during eye movements. Shows up most prominently in the frontal leads. A simple check is to gently cover the patient's eyes. If the waveform disappears, it was likely ERG.
And sweat. I wouldn't have thought of that.
Oh yeah, very common in ICU patients, especially with fever or just heavy perspiration. It causes slow, drifting baseline shifts on the EEG. It can also produce these smooth, high-amplitude slow waves, often in the frontal and temporal areas. It's due to changes in skin impedance and maybe some electrical activity from the sweat glands themselves.
Wow. Okay, so that's the body generating noise. Now, non-physiological artifacts from outside the patient, I have to imagine 60 hertz artifact from all the electrical here is a constant headache.
It is a persistent issue. Ventilators, monitors, IV pumps, dialysis machines, beds, endless sources of 60 hertz alternating current artifact.
Does it look the same everywhere?
It can be localized, just under electrodes near the offending device, or it can be widespread across the whole scalp. Troubleshooting often means systematically unplugging non-essential equipment one by one to find the source.
What else causes it?
Poor electrode contact, faulty cables, bad grounding of the EEG machine itself, checking connections, making sure electrode cables aren't draped across other electrical wires or touching the floor can sometimes help. The notch filter is the last resort, keeping in mind its potential downsides.
Electrode artifacts themselves, like problems with the actual surface electrodes, what do those look like?
If the contact between electrode and scalp is poor or unstable, you can get sharp waves, slow waves, or sudden electrode pops that might mimic focal brain activity.
What about wire movement?
If the lead wires move, maybe the patient is repositioned, or staff adjusts equipment that can create disorganized artifacts. Weird morphologies that might resemble focal or even generalized slowing. These are usually limited to the specific channels connected to the affected electrode.
Nexus.
Proper skin prep before applying electrodes, enough conductive paste, double-checking the integrity of the electrodes and their connections to the jack box. Basic but crucial stuff.
Ventilator artifact, that sounds like it could be really misleading if you didn't know about it.
It can be. It often presents as rhythmic, high-amplitude slow waves, usually most prominent over the frontal regions. And crucially, the rhythm matches the ventilator breath rate.
Can it look like serious brain patterns?
In cases where the underlying brain activity is already very suppressed, ventilator artifact can even mimic a burst suppression pattern, which usually indicates severe brain dysfunction. So, yeah, very important to identify it.
How do you confirm it's the vent?
Try gently repositioning the head. Sometimes placing extra monitoring electrodes on the vent tubing or near the patient's lips helps see the correlation. The definitive test, though, is to briefly disconnect the ventilator with respiratory staff present and managing the airway, of course, and see if the pattern disappears.
Gotcha. Then we have just general environmental noise, movement, and something specific called prisma artifact.
Right. Environmental or movement artifacts are caused by anything physical happening, nearby staff walking, bumping the bed, patient shifts. The key is correlating the EEG squiggle with observation, either directly or via the video feed. Minimizing unnecessary movement helps.
And the Prisma device.
That's a machine used for continuous renal replacement therapy, like dialysis in some ICUs. It produces a very characteristic artifact, a generalized sawtooth waveform, usually around 5.5 to 11 hertz.
What causes it?
It's directly related to the movement of the internal rotor in the device. It can sometimes resemble certain EEG patterns, maybe even epileptiform activity, but it tends to be more posterior, the dead giveaway. It stops immediately if you temporarily cause the Prisma device.
Okay, so with all these potential pitfalls, physiological, non-physiological, it is crystal clear that interpreting ICU cEEG requires serious expertise. You need to know neurophysiology and the tech challenges of the environment.
Absolutely. It's a specialized skill.
Now, the article also briefly mentioned quantitative EEG, qEEG. How does that fit into this picture? Is it a way to cut through some of the noise?
Well, qEEG is presented as a valuable tool, mainly for rapidly screening through those long cEEG recordings and spotting gradual changes over time. It uses algorithms to quantify aspects of the EEG.
Like what?
It can help quantify seizure burden, monitor for trends suggesting ischemia, bleeding, hydrocephalus, brain swelling. There are specific patterns like the solid flame on spectrograms that are highly suggestive of seizure activity.
So it flags things for review.
Exactly. But you always need to go back and review the raw EEG to confirm what the key EEG is suggesting. It's an aid, not a replacement for expert visual analysis.
What about other kEEG types?
Amplitude-integrated EEG, AEEG is another common one. It gives a very simplified, compressed view of brain activity over time. And the bispectral index, BIS, originally for anesthesia depth, has seen some ICU use for sedation monitoring, but its role there is still kind of debated, not universally accepted.
It sounds like cEEG is being used for more and more things beyond just seizure detection these days.
Absolutely. Its applications are definitely expanding, assessing consciousness, behavior, helping with neurological prognostication, detecting ischemia.
How does it help with consciousness after brain injury?
Well, certain patterns in the resting state, EEG, like general slowing or attenuation, meaning lower amplitude, can correlate with how severe the encephalopathy is. Conversely, seeing things like sleep spindles or K-complexes, normal sleep features, can sometimes be a favorable prognostic sign.
Interesting. What about patterns provoked by stimuli? You mentioned serpids.
Right, stimulus-induced rhythmic, periodic, or ictal discharges. These are patterns that pop up specifically in response to stimulation. Their exact clinical meaning is still being actively researched, but they're increasingly recognized.
And even more advanced stuff, like checking for hidden cognition.
Yeah, techniques like event-related potentials, ERPs, or asking patients to try a motor command while watching their EEG active perturbation tasks. They're being explored to assess cognitive function, even in patients who look completely unresponsive.
So you might see brain activity related to the command even if they don't physically move.
Exactly. That's called cognitive motor dissociation, or CMD. Detecting that via EEG can actually predict better neurological outcomes down the line. It suggests some level of awareness is preserved.
Wow. And detecting ischemia, reduced blood flow?
Yes, changes in EEG frequencies can correlate with changes in cerebral blood flow. Measures like the delta-alpha ratio, DAR, and related indices are being studied for predicting stroke outcomes and detecting delayed cerebral ischemia after subarachnoid hemorrhage.
And something called cortical spreading depolarization.
Right, SD. That's a slow wave of intense neuronal activity, followed by suppression that propagates across injured cortex. It's linked to worse outcomes. Detecting it requires specialized EEG techniques like DC recording or specific EEG analysis, but it's another area of active research.
Okay, let's circle back one last time to that Dutch survey. What were the main challenges and future directions they saw for cEEG use in the Netherlands?
The key challenge they highlighted was the need for more uniformity in cEEG practices across hospitals. That includes clearer, standardized guidelines for interpreting the complex data.
Makes sense, given the variability they found.
Yeah. There's also a big push to streamline the workflow, make it less labor-intensive, and move towards true, real-time 24/7 monitoring, not just recording with delayed review.
So closing that gap between recording and interpretation.
Exactly. They emphasize needing more research, especially large collaborative studies, to get robust data on how cEEG actually impacts patient outcomes and to help develop better standards of care.
What about hospitals not using cEEG?
They noted the importance of addressing why some places still don't use it routinely. Reasons include perceptions of it being too complex or infeasible with their resources, and maybe a perceived lack of really strong evidence showing it definitively improves outcomes, though that evidence base is growing.
Okay, so wrapping this all up, this deep dive really shows us that cEEG is, well, a super valuable and increasingly vital tool for watching the brain in the ICU.
Definitely.
But as we've explored, it's complex. There's significant variability in how it's actually used day to day. And maybe one of the biggest ongoing challenges is consistently and accurately sorting out the real brain signals from that absolute zoo of potential artifacts in the ICU environment.
That's spot on. Mastering artifact recognition isn't just like a technical skill, it's the crucial filter. It determines if you're truly seeing the patient's brain or just the electrical noise surrounding them. So, by digging into these nuances, from the organizational differences we saw in the Netherlands to the critical technical bits about getting a good signal and understanding all those different artifact types, you, the listener, now have a much clearer handle on this vital aspect of brain monitoring and critical care.
And that brings us to a final thought for you to chew on. Given that cEEG use is clearly growing and its potential to give us crucial insights is undeniable, how can we best work towards standardizing practices? How do we better integrate the tech needed to make sure reliable, interpretable brain information is available for all critically ill patients who could benefit?
Yeah, and looking ahead.
Exactly. What are the next big innovations that will finally let us move beyond just recording brain activity to having truly continuous, clinically actionable, real-time monitoring of the brain in the ICU?
Definitely something to think about.
It really is. Thanks for taking this deep dive with us.